So how do we define psychological disorders? Well, defining psychological disorders is not going to be so simple. Given the history that we've talked about with all of the changes regarding how psychological disorders have been perceived by people over the course of hundreds of years, there's actually going to be a much more complicated story in this case. It starts with a fairly typical sounding story from the 21st century. Males have dominated Western science since before 1600. But this is actually a true issue that actually has some bearing on how psychological disorders get defined today. And the problem is this. Because most of the scientists in general have been male, for the areas of study in which they've been evaluating biology, in particular human medical treatments, most of the medical researchers have actually used themselves, other male doctors, as the primary way to evaluate average height and weight and heart rate and temperature and all the other things that they might actually measure. They all generally come from males. Now, in most cases, it's really not going to be that big of a deal. But whenever there were differences between males and females, the one logical flaw that wound up being used was that it was assumed that when women had different measures than men, that the women had aberrant measures. There was something deviant about the female characteristic. That, women on average are shorter than men. Well, that's probably because of a deficiency of some sort. But their temperature is the same, so all of that is completely normal. Those kinds of things probably don't play out in that degree of importance. However, when you get to psychological disorders, there are some significant problems that actually start to show up. But keep in mind, even though this issue started around 1600, it was true well into the 20th century. And it is an issue that will not really be forcefully addressed until about the 1960s. During the 1960s, the reason why things get addressed at this point is largely related to the things that I've told you back in the personality chapter. That is, the Vietnam War was going on. There was a lot of social protesting about the war, and it led to a lot of secondary complaints as people organized themselves into political action groups, let's say against the Vietnam War, or about communism in the Soviet Union and so forth. There were offshoots that developed about things regarding medicine and psychiatry. One of the more popular treatments for the field of psychology, even still in the 1960s, was a Freudian approach. And the Freudian approach was really largely based upon a male-dominated 19th century approach created by Sigmund Freud, an approach in which a single individual, the therapist, sat in judgment of the patient. There was nobody that they had to talk to get another viewpoint from. It was just the therapist, and the therapist essentially functioned like God to determine the prognosis, the diagnosis, how the person should be treated, and so forth. And that, of course, leads to a substantial problem, because whenever characteristics are viewed between males and females, or between the psychiatrist and the patient, there's always a greater likelihood that the therapist will kind of perceive that there's a more significant problem if the patient has a psychological traits that are different than the therapist themselves. So that is, the greater the distance, the greater the psychological differences between the therapist and the patient, the more likely that the therapist would see that the patient had a significant psychological problem. If the patient was somewhat similar to the therapist, then the therapist would be more likely to just kind of blow off the problem as maybe something not that important. they would probably realistically have more of an insight into it and probably be more likely to give the patient some leeway regarding how it should actually be treated. But the broader story of the field of psychiatry in the 1960s was that it was still largely dominated by the Freudian approach. And during the 60s, a lot of questioning started to take place regarding how the Freudian approach was causing different forms of social bias, in particular gender bias in terms of psychiatric treatments. And as a result, these issues started to get addressed. The field of psychiatry had to recognize that there was a problem, and so eventually there were some changes that occurred to try to fix these issues. The one primary issue that had to be addressed was the fact that a single therapist sat in judgment of the patient. Now, of course, when you go to a medical doctor, most of the decision making on the part of the physician is done based off of the training, and the training was based upon group studies. So, a medical doctor evaluates your temperature and your heart rate and your breathing rate, but all of the standard expected temperature, heart rate, and breathing rate come from charts that the medical doctor is already familiar with, and so they could judge you as having a high or low temperature, a fast breathing rate, or a slow heart rate, and so forth. But how much psychological disorder be present in an individual before you need to address it, right? How often do you have to think that your friends are against you so that it starts to look like a formal aspect of paranoia? How often do you have to become mad that other people don't do what you want before you start to recognize the person is narcissistic? These kinds of comparisons don't actually exist in charts. Nobody has studied them. And so the way to gauge these problems is to have more people look at the problem itself. So what will ultimately happen is the field of psychology and psychiatry will start to recruit more female members into medical school and to graduate education so that the population of therapists is not primarily male. As things have actually changed, the psychiatric treatment team approach was developed as a way to address the issue of the single therapist making the decisions about a person. And the way the psychiatric treatment team approach has been applied is to fall back on the biopsychosocial approach. The biopsychosocial approach has the biological, psychological, and social aspects addressed for a psychological illness. Those three components are addressed by a medical doctor, a psychologist, and a social worker. So you see the psychiatric treatment team is made up of one expert from each component of the biopsychosocial approach: a medical doctor, a psychologist, and a social worker. And those three individuals have to address a mental illness based on 4 standards. Not whether or not they think the person's crazy or not, but they have to address the issues of the mental illness in 4 categories: the statistical infrequency of it, the disability that it causes, the personal distress it causes the individual, and the violation of norms that it may cause. And those 4 characteristics have to be marked yes by each of the 3 individuals. So that's 3 individuals identifying 4 separate categories. So that would be a total of 12 check marks indicating yes. And the gold standard by which the psychiatric treatment team approach operates is that there has to be a full set of 12 yeses. The individual's mental illness occurs to a statistically infrequent amount, either too little or too much, that it causes a secondary disability, that it causes the person a personal distress, and there's also cultural or local norms of behavior that are violated as a result of the disorder itself. We'll take a look at those more carefully in a couple of slides, but the way to see the psychiatric treatment team approach applied is here in this particular video. What you'll see is both the psychologist and the parole officer, who essentially serves the role as the social worker in the scenario for a convicted pedophile. One person missing from this video is the medical doctor, who generally would not attend regular therapeutic meetings with the patient themselves, because mostly the role of a physician in terms of the treatment approach is to decide what kind of medical intervention, which today means basically pills, what medication should this person get if they get anything.
Through treatment, Terry Case has learned to talk openly about his crimes.
I was sentenced as a sex offender. I have 4 victims, starting with my first victim, which was 6 months old. Then I have my second victim is a 14-year-old cousin. And then my third victim is my oldest daughter, and I started molesting her when she was 6 years old. And then my last victim is a daughter of mine, which is my third child, and I started molesting her when she was about 6.
How do you think most people would view you?
Most people probably view me with disgust because of my child molestation, that they're not happy with me. It is a hideous crime of what I have done.
Both out on parole and before that in prison, Terry has had therapy to help him conquer his perversion. For him, parole and supervision are working. And he accepts that he needs to go on having treatment. While he's rebuilding his life, it's vital Terry has people he can confide in. But he knows he's hiding things from those who are counseling him. He has regular meetings with his therapist and Bill Lassiter, his parole officer, to discuss his progress.
Jerry said that you had your homework done, and he thought it was important that we bring it up in this networking session. So what do you want to talk about it?
I catch myself several times just driving around and stuff like that there, and I'll see girls walking down the street, and I know they're just little girls and stuff, and I'll look at them and ooh, that's a cutie, and you know, got a nice little butt and all this type of stuff, and that's, you know, and then don't do that, you know, and I'm hiding that. That's the secrets and the lies.
Terry, is this the first time that you've shared these bad thoughts you've had with us? The fear, the looking? Is that the first time you've shared that with Gary and I?
Yep.
Terry, you were talking about watching or seeing these young girls walking down the street. Are there any fantasies that you have in terms of, even when you stop yourself and you say, I can't think about that little girl that way, later on, an hour later, that evening, or when you're home, you're by yourself, or you're masturbating, do you have sexual thoughts then of that scene?
No, that I don't have. That, so, you know, yeah. See, and that's one thing that gives me a kind of an indication that the programming's working. You know, but the thoughts are still there, and as long as I keep that little secret to myself, I'm hurting myself.
Yeah.
You know.
Well, Gary, isn't it initially you're going to...
Bill Lassiter says it's important that Terry is not isolated and that he has the opportunity to discuss what's troubling him.
To bring that out, to bring that open, It was very scary for him. But by doing that and being able to do that, he's made another step showing that treatment is a success, that he is learning to be open and honest. He is learning other behaviors. We even discussed when this thought comes across his mind, does he continue with it? Does he fantasize over it? Does he masturbate over it? And he doesn't. He says, no, I can't do that. I've got to do something else. So his learning outlets is succeeding.
Now, in what realistic manner would a medical doctor fit into Terry's treatment team? And of course, the correct answer in this case is going to be drug treatment. This issue of what a medical doctor could do in the case of a pedophile will very rapidly reach a violation of civil rights or ethics in this particular case. If there was any kind of penilectomy or castration, those are treatments, even if you consider them seriously, that actually would be irreversible. And this is the problem in terms of ethics. If you do something as a medical treatment that cannot be reversed, then it's unethical. And that's because you can't expect 100% of all people to have a positive outcome from some particular treatment. There's always variability. And so if you knowingly give somebody a treatment that you cannot reverse, it's automatically off the table. The answer E, of course, Freudian therapy should be absolutely incorrect. I think we spent enough time in the personality chapter telling you about how Freud has no value today, and so it's certainly not an option. A frontal lobotomy, of course, is another medical treatment which is going to be permanent because you're damaging central nervous system tissue. The only possibility here is going to be drug treatment. And about the only drug treatments that you might possibly give somebody, and of course it depends upon the particular individual and maybe secondary issues that they might have related to the pedophilia, is a treatment for anxiety or other drug treatments that might reduce sexual interest in general. And that's about the only thing that a medical doctor can actually do at the current time. There are simply no other medical treatments for pedophilia. The treatment's primarily going to come from traditional talk therapy, as we've mentioned before, the retraining of thoughts, emotions, and explicit patterns of behavior. Those are going to be your best opportunities to change things. And depending upon the person, problems like this can be reasonably easy to fix, and they might also be actually rather difficult. It very much depends upon the person. Now, there were 4 categories to identify abnormal behavior, and I mentioned those a couple of slides back, and I said that we would talk about them in detail, and here's where we're really going to hit them. The psychiatric treatment team approach requires that a medical doctor, a psychologist, and a social worker all make judgments about an aspect of mental illness with respect to each of these 4 categories. Now remember that this is a replacement process for the one therapist, one decision process that had existed from the standard Freudian approach. That was still at least common in the field of psychiatry, not so much psychology, but in the field of psychiatry into the 1960s. Statistical infrequency. How does that affect things? How does that help you determine whether or not a person has a psychological disorder? Well, statistical infrequency simply means that the pattern of behavior in question either occurs much more than people in the general population or much less than people in the general population. That's it. If a problem of behavior occurs to the same amount as everybody else in society, then forget it. It's not a mental illness because they're doing something that everybody else does, and therefore it cannot be considered abnormal. So from that standpoint, it should be even clear to you that as society changes and culture changes, what actually constitutes abnormal behavior will change. So even if you had gone back 500 years, for example, and we're talking about people talking to themselves, potentially having hallucinations or delusional thinking, things like that today, we automatically blow them off as aspects of mental illness, whereas back 500 years ago, they might have been components of devil possession. And so there would have been a completely different view of it. And as time changes, the patterns of behavior that people exhibit would be considered inappropriate or abnormal. And that's even true across the 20th century. Patterns of behavior that would have been considered very abnormal back in the early 20th century would be completely normal now. Disability or dysfunction. Disability refers to a secondary disability that may occur as a result of having a psychological disorder. So, for example, common example I give would be of a homeless person living in Miami. If a person has been living on the streets in Miami for the past 10 years, they may be more prone to developing skin cancer because they're simply outside quite a bit more. And as a result, you as a person from the treatment team would have to judge whether or not the skin cancer was considered a disability or dysfunction secondary to their homelessness. Now, you could judge it as just a natural outgrowth of this person's decision to live out on the street, not be part of society, to not work 9 to 5 and be part of the rat race. Or you might just say that they are developing cancer as a result of their life choices, and so it actually is a disability. This is a decision that you have to make as a member of the treatment team. Is there a universal standard by which you're going to go by? No, actually there's not. And in fact, in this whole process, which you see very much, this process is a construct. How are you defining what's mentally ill? Well, you're part of the treatment team, and you're having to make a judgment about another individual. You and 2 other people from the treatment team approach. Your decision may be a yes, your decision may be a no, but it's going to wind up affecting the overall likelihood that this person either gets medication, goes back to a psychiatric facility, or maybe even goes home. And a lot of this is still a little bit based upon your own personal decisions, because even at the current time, there are no strict standards or charts that you can follow that establishes how human behavior will always operate one way or another. When you measure somebody's heart rate or temperature or the breathing rate, there's going to be a fairly small range around the average. But when you ask about how paranoid should somebody be about their friends, how much anxiety should you have, how much concern should you have about losing your job, there's just too many things that you could ask about and too many ways in which people deal with it for you to actually establish universal charts to make decisions from. And it all comes back to you as an individual making a judgment about somebody else. Personal distress. One thing that most people are not aware of is that an individual with a psychological disorder generally is aware that they have a problem and is also uncomfortable with it. Now, this is not always the case, but it most likely is. People that hallucinate, see giant spiders or Satan coming out of the ground, people that are paranoid or think that pirates buried treasure underneath of their house, if you get them onto medication and talk to them, they will generally recognize and say that they know that those things are not true. But during the time that they're experiencing symptoms, they treat it all as true. And so they respond to these thoughts as though they're real. once the person has been calmed down with a medical treatment, for example, then they recognize that it's not true. And when they recognize that it's not true, it generally causes them some distress. There are few problems that cause people no distress. They often tend to be related to things like personality disorders, where people live their lives in particular ways that are not really oftentimes to their advantage. And they may have a paranoid personality, for example, so they may be very suspicious of other people, but they won't see that the way that they generally live their life and kind of being suspicious of others is a problem, because they're going to have just a process of logic that they use, that they believe, that reinforces that they cannot trust anyone. And so they're going to have very little distress about it. What they'll have is more distress about the fact that nobody can be trusted, rather than distress about the fact that they think nobody can be trusted. And finally, the violation of norms aspect really very closely ties in with the aspect of culture. And of course, culture changes over time, so this is going to be an aspect of decision making about violating norms that's going to change over time as well. Violation of norms refers to the current cultural standards at the current time and whether or not a person violates them. So, for example, at one time, let's say 100 years ago, if a woman always wore slacks like a man, then that would have been considered a violation of norms, and possibly indication that there was a psychological disorder. The same would actually be true today for a man who only wears a dress. Okay, so not even on occasion, but if a man always wears a dress every single day, puts on a full face of makeup, and just lives their life that way, that would fall into a category of mental illness, at least specifically from the component of violation of norms. And that's simply because you don't see men who just wear women's clothing, traditional women's clothing, all the time. Simply doesn't happen. And so it would match with the statistical infrequency story as well, because how many men actually wear women's clothing every single day? Very few. And so then you have both a violation of cultural norms and statistical infrequency, which would be two components of all four to establish a psychological disorder. So now we have a couple of questions to ask ourselves about these issues. One, why was there a picture of Joseph Stalin on the previous slide? Very odd question, but take a look at the answers and let's see if you can get it. The correct answer is A. Stalin was one of many dictators who manipulated psychiatric categories for political needs. This is very true around the globe. It's actually a process that still occurs, but although you don't see it that often as much anymore, during the early 20th century, it was actually much more common. In fact, plenty of instances of this, for example, if you're just talking about Soviet Russia, where a dissident, a person who does not like communism, goes to their own house, types up, letters for their friends and distributes them, talking about how the communist government is not really helping the Russian population. And if the government ever figures out who does this, it's possible that that person will simply be declared mentally ill and then sent off to a psychiatric facility. But it's not because somebody truly thinks that they're mentally ill. They're just using the older Freudian approach for psychiatric diagnostics to establish the person as mentally ill. Because you only need a single individual to be able to declare the individual mentally ill. And so when you use that older Freudian approach, you could just have a government psychiatrist declare that a person who does not understand that communism is the best government clearly must be mentally ill so that you can have them placed into a psychiatric facility, which is, of course, a simple way to shut them up. But this issue did not happen only with Joseph Stalin. Hitler did the same thing. Plenty of dictators in South America, Chiang Kai-shek, Pol Pot. The list of people that have used psychiatric categories as a way to suppress political rivalry, a long list, and has been around for over 100 years and still occurs in some places on the globe today. And our final question before we finish here: the diagnostic criteria for mental illnesses before the 1950s was primarily developed by Freudian psychiatrists. That is absolutely true. And in fact, to see what new diagnostic system develops in the 1950s is where we're going to start in our next video.